My name's Richard Sainsbury. I'm one of the breast surgeons at 108 Harley Street. Been here for about 20 years, having arrived from Yorkshire when I was a consultant for 15 years before coming back to London. I've been carrying out medical legal work for about 35 years, and I just thought I would share some of the aspects that might impact on your practice or might be of interest. So we'll go to the next slide, please. We can start by having a look at who gets sued. Everyone, basically, is the answer these days. It didn't used to be, but now anyone who deals with breast work is in the frame. That starts with the GPs, and I'm going to address these in detail, through our radiology colleagues, through our surgeons, the plastic surgeons. Increasingly, breast units get sued rather than individuals, because in the NHS, at least, they're the liable body. And that in itself creates problems, because on some occasions, the individuals working in the unit don't even know that there has been a claim against them, and that this is dealt with just by the legal department. And now increasingly the experts are being sued. There have been 2 cases recently where the experts have had to pay back the costs of a case because their expertise was inappropriate or they gave the wrong advice. One of them had to pay back £88,000 last year, and the year before someone had to pay over £70,000 purely because their expertise was not up to scratch. So something to bear in mind if you're thinking of taking this work on. Next slide, please. And why do people get sued? Well, for the GPs, it's mainly delays in referral. And I remember way back starting as a consultant in 1988, the local GPs in Yorkshire where I was working, several of them complained and said, Richard, it's terrible having an expert in the infirmary, because now everyone wants to be referred, and it's taken away our looking after patients and our ability to decide what needs referring and what's not. Those days are long gone, and if cancer's missed, it's automatically assumed there was a delay in referral. And that's something I think that the GPs take on board. They're much better at safety netting than they used to be, and they're cognizant of the guidelines for referral, but consequently they refer in many more patients, and we see a lot of people that in the past would never come to clinic. The radiologists, normally it's missed lesions, or was there something there at a previous time. The radiologists are actually very good in the screening service, which I'll come on to in a minute, at looking back at all their cases and classifying them, but they are in the frame. Surgeons get sued all the time, and they're mainly because of delayed diagnosis, but increasingly for surgical errors such as not taking out the right bit, operating on the wrong breast completely, which is a never event, and more increasingly with the rise of oncoplastic surgery for poor results. Plastic surgeons get sued for poor outcomes. They take on potentially a higher risk group of patients who want, especially in the cosmetic world, who want an outcome that may not be achievable, and so they're in the frame for that. And as I said, breast units now for everything. And the experts, if the court thinks they haven't fulfilled their duty, normally it's the disgruntled opposition party that will examine if they think the expert has provided the right level of expertise, but then that's taken back to court, and the court will decide if the expert has or hasn't fulfilled their duty. As I say, increasingly we're seeing this happen. There hasn't been a breast one, to my knowledge, yet that's come to court. I do know that one expert did have to refund his fees, and they no longer used his report, but I haven't seen a breast one come to court, but it won't be long. Next slide, please. And what happens if we drill down to look at these in more details? The GPs, the complaints mainly are that they failed to examine properly. And for new GPs, this can be a real problem because many of them have only ever been to a breast clinic, maybe on one occasion in their training. And depending who they saw or worked with, they may not have been shown how to examine the breast properly. I'm still amazed at how many talk to the patient. You never say, what did the GP examine you? Because that's a bit inflammatory. But you ask them gently, and what did the GP say when they examined you? And so, still a number of patients will say, oh, you never examined me, just sent me in, or just sent me on my way. And so I think there is that element of failure to examine properly. And that can be cultural in some areas of the country. If it's a male GP and a female patient and there isn't a chaperone, but even so, that's a failure of duty. Then there's failure to listen to the patient, and you or the GP will know the patient and should know when a complaint is different, or if there's a serious nature to the complaint. I think the patient, the heart sink patient that's always in surgery, has got very thick GP notes and slips in something at the end of a consultation on their recurrent skin problem or their recurrent depression, and at the end just slips in, and by the way, I think I've got a breast lump, they can be dismissed. And I think that's almost a red flag that someone who slips something in at the end is actually what they're concerned about and needs taken seriously. Then there's failure to refer. So the GP's described a lesion and then not done anything about it. Now, it's perfectly acceptable for the GP to re-examine the patient 6 weeks later. No one will be criticised for that. But if that's put down as a reason to see the patient, then that must be followed through on. And if the patient fails to re-attend, that there needs to be a safety netting so they can be called back. And the other thing that I know anyone who talks about medical legal work talks about is record keeping. It used to be that if you kept no record, then the court would accept that what you did in your normal practice would be valid, but that's no longer the case. If it was not written down, it didn't happen, and therefore the court will find against you, or the facts of the case will be found against the GP early on. So my one plea, as I'm sure you've heard many times before, is accurate records made contemporaneously. If they're made afterwards, make it clear they're made afterwards and the reasons why. I did a case recently where the patient, but more importantly her husband, saw the GP write nothing at the time, and the GP leave the room, get in their car and drive off after seeing them. So they didn't write the record at the time, but later claimed that they'd written a contemporaneous note without saying that this was actually written 2 days later, and that caused problems. So contemporaneous records, accurate, with details of any safety netting, are vital. Next slide, please. Radiologists, there are 3 groups that get into trouble. Those carrying out the screening mammograms and screening service. All mammograms are double read these days. That means that either 2 radiologists or an experienced radiographer and a radiologist look at the images, and they both have to agree on the diagnosis, or on whether the patient is returned to recall or not, to routine recall, or whether they're called back for assessment. For every 100 patients screened, 10 will be recalled for assessment, and of those 10, 9 will be discharged at that time, with only 1 going forward for either further tests or onto the breast clinic. But if a lesion comes up between screening rounds, it's immediately assumed that it was missed by the screening radiologists, which is why they have a very good system of looking at interval cancers and assessing whether this was a true miss, or whether this was a lesion from which there are learning points, but it wasn't genuinely missed, or whether it was genuinely not there at the time. And some breast cancers will occur between screening rounds, and people must always remember that 10 to 15% of breast cancers don't show on mammography. That's either because they're at a site that the mammogram doesn't pick up, or that they don't have the characteristics that can be easily determined on a 2-view mammogram. So screeners are one group. The diagnostic radiologists who miss a lesion or image the wrong part of the breast, certainly for younger patients, those under 40 where they don't have a mammogram, they only have ultrasound. Ultrasound's fine if there is a lesion there to determine between solid and cystic or characteristics are there, but in a dense breast it can be difficult, and if they don't image the right area they can miss it. And the group that also caused some concern are the increasing use of radiographers, some of whom are superb, some of whom need, I think, additional training before they carry out this work. And we do see a number of cases where radiographers done the ultrasound, and when it's been reviewed or the images have been reviewed, or whether ultrasound's been repeated by a more experienced person, that the lesion is detected. So that's a group that need, I think, some additional help on occasions. Next. Surgeons are open to lots of medical legal attention, and I don't know any colleague who hasn't had a medical legal case against them. I certainly have over my time, but you know, it is one of the risks of the job. One of the things is that in the NHS, certainly the busy breast clinic, you have a number of staff with you, you have some trainees, you have to delegate. At one time, the guidelines suggested that every patient was seen by a senior clinician. That's just not possible. The other thing that, one thing that is increasingly apparent is that once something's written in the notes, then it's assumed that that's correct and stays in the notes. And I've had a quite interesting case recently where a lady came in 2015 and said that she had had a genetic test and it was positive, and quoted a unit where she'd had the test, which was entirely reasonable. And so she was labelled as a BRCA2 carrier, and that got into the notes. And 10 years later, so it must be 2005, and so in 2015, 10 years later, she comes and says, I've been thinking about it and I'd now like a bilateral mastectomy. So the surgeon looked through the notes, saw BRCA2 carrier, and talked to her about it, and she was adamant this is what she wanted. And they did the bilateral mastectomy and nothing was found, and then tested the daughter who wasn't carrying the gene, and it turns out that the patient was under the misapprehension she'd been tested and was positive, and so she'd had an unnecessary bilateral mastectomy, for which she then proceeded to sue. It was interesting that it was an SHO way back when he first met the patient in 2005, who wrote this down, and that then got propagated in the notes and assumed to be true. The next group are, again, like the GPs, ignoring patients' concerns. We have patients who come to clinic and say, but there is something there. I know there's something there. I know my breasts. And they're a group that I think you need to listen to very carefully. Increasingly, we're encouraged to discharge patients at their first visit after appropriate examination, history examination and imaging, mammography or ultrasound. And if there's nothing there, say goodbye to them. But there are a few patients where there should be a little bell ringing at the back of your brain, and it's worth reviewing them maybe on one occasion just to check that everything has settled. Not examining properly, that shouldn't happen in a surgical clinic, but it does. Not investigating properly does happen, where if ultrasound isn't available on the same day, used to often be the case because there weren't enough radiologists carrying out ultrasound, or saying, dismissing symptoms and saying you don't need imaging. Wrong surgery. So those are all acts really of omission. Then there are acts of commission. The wrong surgeries. I had 3 recently where the wrong area was localized, or the specimen X-ray wasn't taken, and so the patients all had to have a second operation. One of them, it switched from a wide local incision to a mastectomy, so that was unnecessary had it been done properly the first time. We're seeing increasing number of people describing themselves as oncoplastic surgeons. Although there is a training program, there are a group out there who haven't been through the oncoplastic fellowships, and some of the results are not good. So the consent process is poor. Use of guidelines has become more and more. We have guidelines for absolutely everything now. And the trouble with guidelines is that if you step away from them, be accused or attacked. And we're seeing guidelines used as a weapon. They shouldn't be. They're there as a guidance, not for obedience. But once it's written down in the guidelines, it becomes more difficult to defend. And then there's GIRF, get it right first time, which Fiona McNeill from 108 has been leading on in the breast sphere. And this is a concept about not repeating, having to repeat things and getting all your ducks in a row at the first time. Next slide, thanks. There are some of the guidelines we have to adhere to. So there's the best practice diagnostic guidelines. There's the oncoplastic breast reconstruction guidelines. There's the NICE guidelines. And then there's the screening program guidelines. So within this, all these are apple pie and motherhood statements, some of which are unachievable in a busy clinic, or there are reasons why you don't do it. But if you step outside from the guidelines, it should be written down why you've done so. And then that's easily defendable. Next slide, thanks. Plastic surgeons, one of the reasons I put hubris at the top is that the plastic surgeons are quick to criticize, but quick to take offense. They don't like doing medical reports because medical reports don't pay very much compared to what they earn without working. And actually, their hubris sometimes leads to not providing the best service. And this is particularly so in some of the clinics like Maya or Transform or a medical group, or whatever they're calling themselves these days, where they'll buy in a plastic surgeon, even if breast isn't their special interest, and they'll give them an information sheet so they can tick the boxes so it looks like everything's being done. But this isn't their routine operating sphere, and yet they take criticism badly. So their information giving has got improved greatly. They have BAPRES guidelines, they have sheets outlining the procedures, and this is important with the change in law and the Montgomery judgment. But even so, sometimes the information is given in such a way that the patient can't take it in. They're at a high risk because many of these patients have demands that are impossible to be met. I always had a rule that when the patient came to see me, if I didn't like them or I didn't think that they were amenable to listening to the guidance and to the advice, that I wouldn't take them on. There's always someone in town who'll take the patient on. I think it's really important if you're going into a cosmetic area that you have a relationship with the patient, and that you also teach them that 50% of your results are going to be below average. By definition, you have an average result, half of them will be below average. And that's not something that patients really want to hear or take on board. We see plastic surgeons who aren't breast surgeons or aren't used to dealing with breast, not investigating properly. There's a lump in the breast, but they don't bother investigating. They just get on with the reduction or the augmentation. And lo and behold, there's a cancer there. And there's now guidance from the plastic surgery authorities that these people should be investigated properly there. Some of them do get poor outcomes. some of that is unavoidable, but when the poor outcome is poor, some of them walk away from the patient, and that's unhelpful. Consent forms are much better than they used to be, but even so, there are those who don't use them properly. And then many plastic surgeons haven't heard of Get It Right first time and say, what's that? And so there is still a learning area, I think, for some of our plastic surgery colleagues. Next slide, thanks. So what is negligence? Everyone has an idea what negligence is, but it's the court's word. It's not the experts, and it's not the claimants, and it's not the defendants. The court determines whether negligence has taken place. Got told that many years ago when I did go into court, and the plaintiffs, and I think I was doing the defence, and the claimant said, "Do you regard this as negligent?" And I said, "No." And the judge leant forward and said, "Mr. Sainsbury, it's for me to determine negligence, or here to advise me." And so I'm very keen that people don't use the word and that it is the court's word. But basically, it implies a failure to achieve a standard that no ordinary practitioner in that field would do so. And there are two classic judgments, the Bolam judgment and the Belitho refinement of that, that set this principle out. And so that if a surgeon does something that falls within the standard that most normal surgeons would do, and it's subject to a logical analysis, then it's defendable. So breach of duty would not be implied. There has to be both breach of duty, but then causation, so that some damage has to flow if breach of duty is found. These are the two major principles. And today's talk's not really about the law side of it, it's more about just to fill that in. And now increasingly there's another judgment, the Montgomery judgment, which is that the patient has to have enough information in a form they can understand that they can give an informed consent. And this really has changed the way one talks to patients, one consents them in a big way. And this is something that since 2015 is increasingly important. Next slide, thanks. Breast medical legal work is expensive. It's second only to damaged babies in the NHS payouts. Damaged babies, obviously, because there's a lifetime of care, are very, very expensive. But in total volume, because breast is so common, it's an expensive area for the NHS. There's a tariff of damages. For instance, if someone has a mastectomy instead of a wide local excision, they may get £2,000 to £3,000 for that. But if they get lymphedema where they wouldn't otherwise have done, get 20 to 30,000. And it gets really expensive when there's loss of a chance of life, so that if the delay is meant that a more advanced cancer is presented, but it can be shown that their life expectancy has been shortened, then it will run into potentially the hundreds of thousands, especially if there's earnings taken in place. The most expensive single case I've been involved with was where a surgeon was operating on his 5th private hospital in that day, and went in to see the patient who had DCIS, pre-invasive cancer in their breast, and decided that in addition to doing a mastectomy, he'd do an axillary clearance, which wasn't necessary. What was worse was that this patient had had cable grafts from a brachial plexus injury years before that gave them a functioning arm. The axillary clearance, all these cable grafts got removed, so the patient was left with a useless, non-functioning arm. And they got initially £750,000, which was later increased to and so that was an example of a pure surgical mistake where they didn't listen to the patient, they didn't stop to think, and they just rushing. It was indefensible. The Patterson case, of case being Patterson, who was convicted of wounding patients, specimen charges, is now serving 20 years. is a salutary case for us all. It's also a very expensive case. It's still going on. The coroner has referred every Patterson breast case that subsequently died. All of my colleagues meet once a fortnight to do a virtual MDT to review all these cases. And so far, it's with all the legal fees and everything, Patterson's cost over £100 million. But with settlements that have been done so far, legal fees and the ongoing litigation, just shows the eye-watering figures that are involved these days. Next slide, please. So what do I do as an expert? I try not to stray outside my area of expertise. It's easy to do, but one will get hit for 6 in court if one does. The report these days is to the court. It's not for the individual. You are an independent expert. Not like the old days where experts were for hire for one side or the other. Indeed, there's the, I'm sure it's apocryphal story of a Harley Street surgeon who went to court on a Monday and the judge said, "Oh, good morning, Mr. X, and what expertise are you professing for us today?" So that those were the bad old days. Now you have to be completely independent. You can't take the patient on, even if the patient, claimant or defendant, wishes you to look after them in the future. You can't do that. I think it's important you prepare reports, both the plaintiffs and the defendants, because then you can see both sides. Defendants' reports pay much less well than the plaintiffs' ones, and I have colleagues who will only do plaintiffs' reports, but they increasingly expose themselves because they nitpick or they try and find something in the guidelines which doesn't reflect everyday practice and real life practice. And that's where an expert on the defence who's worked both in a district hospital and a teaching hospital, so can really put it into context for the court, is quite useful. We have to attend yearly update meetings to show that our medical legal expertise is up to speed. Other areas of work, GMC hearings, I try and avoid them. They take a long time. They're not very cost effective, and it's an iniquitous way of dealing with with complaints. And so really as a principle, I try and avoid them. Some of my work is personal injury work, which is mainly seat belts, injuries after road traffic collisions and people who tripped and fall. That's a minor bit of my work. Delay in diagnosis is a major bit. Then increasingly the oncoplastic surgery and poor outcome. Next slide, thanks. This is a typical road traffic. On the left is a lady who's been involved in a road traffic collision as a passenger. So the seat belt's gone across the right breast and damaged herself. On the 3 pictures on the right of the screen are a lady who's a driver. She's got the classic left-sided hematoma, the abdominal hematoma from the seat belt. But when I saw her for her condition and prognosis report, some years later, her breast is essentially normal, which is the lower picture, except she's got a little bit of nipple inversion on that side caused by the damage. It's important to remember that the postmenopausal breast suffers damage much more than the premenopausal breast, because it's basically fat replaced and it withstands trauma. Fat withstands trauma much less well than the elastic breast of the younger patient. The group that causes the most concern are those that have got implants in, because they will find or discover that their implant doesn't look the same afterwards, and one has to try and work out whether this was caused by the accident or whether this was just the natural variation in shape that occurs. This can be quite a difficult group to deal with. Next slide, thanks. Delay in diagnosis is a big issue, and there's a lot of debate about whether it impacts on the patient or how much. We all agree that delays of less than 3 months are non-consequential. We all agree that tumour grade stays the same with time, but the worry is that the delay might cause a detrimental effect on long-term survival, the impact on disease-free survival, the need for more mutilating surgery with greater psychological impact, so a mastectomy instead of a wide local excision, the need for more adjuvant treatments, more chemotherapy instead of just endocrine therapy. Then if they recur, the palliative treatments, and the whole psychology that they believe that a belief in delay has occurred and has impacted upon them. So these are all big issues that we have to face when we do our reports. Next slide, thank you. Here's a patient who see 2 mammograms taken 9 months apart. The one on the right clearly shows the lesion in the upper outer quadrant. The one on the left shows the area, but it was dismissed as an intramammary lymph node. No biopsy was taken, was dismissed. 9 months later, as I say, she came back, had another mapping with a little bit of skin dimpling, came back, had another mammogram, it was biopsied and shown to be a cancer. So there was a delay in diagnosis. Did it matter? Well, the trouble was when they biopsied it, this cancer was surrounded by a large area of DCIS. By the time they'd removed that, they removed over 3 occasions. They'd removed so much tissue, she needed a mastectomy. So she went from being essentially something treated by a wide local excision to a mastectomy, plus the need for all the additional surgeries. Now, was that the fault of the radiologist for not diagnosing it properly the first time, or was that the fault of the surgeon for not taking it out properly? These are all things that need sorting out in report. Next slide, thanks. We have this concept of the tumour volume doubling time. So a tumour, as in that previous case, was there for 9 months. It's unusual to have 2 X-rays so clearly 9 months apart, but therefore you can work out what the doubling time of that tumour was. But if you've only got 1 measurement or diagnosis, you've then got to try and work out what size the cancer would have been at an earlier stage, and therefore was it detectable, and because cancers under a centimetre are thought not to be palpable, and what was the chance of there being no positivity. And this is a highly controversial area. It's not an exact science, and everyone assumes that a tumour is a sphere. You have to for the calculations, but it's often not a true sphere, because if you've got a 5 centimetre cancer, it's probably only 5 centimetres of one measurement, and the other measurements may be well smaller than that. So that if you calculate it as a sphere, you get a false impression of the volume of diagnosis. The other problem is there's a huge range in doubling times from 40 days to 400 days in the literature, and knowing which doubling time to apply. And lengthy arguments between the experts about that. Next slide, thanks. We have outcome calculators, which can be useful if you calculate their survival at the time of diagnosis and then put back the putative figures early on. You can work out the difference. One in the UK that's most used is Predict. I guess most of you use this with your patients. If not, I would suggest you have a look at it because it's a useful tool. There's an American one called Cancer Math. There are older programs like Adjuvant Online and even the Nottingham Prognostic Index, which was the first attempt to make a prognostic index, which are not used now. Next slide. Predict is available online, NHS website for Predict. Next slide, thanks. And you enter a next slide, please. You enter a number of questions, some of which tell you about the patient, some of which tell you about the treatment, some of which input the histology. Next slide, thanks. So if we take a 42-year-old with a triple negative cancer, so negative ER, negative for HER2, the high Ki67, so proliferating fast, say it was 3.2 centimeters, grade 3, and there were 2 positive nodes. Next slide, thanks. You then get the results, and the results are presented 4 ways, and I put all 4 on this slide here, so you can pick the results at 5, 10, or 15 years. So I've just picked 10 years here. You can present it as figures so in the top left, you get a 54% survival from surgery alone, with a benefit of 13% from chemotherapy. And then that can be presented graphically in different ways, which can be useful for the patient or to help their understanding. And you can, as I say, do this for 5, 10, and 15 years. Next slide, thanks. So to summarize, breast litigation is common. And if you haven't experienced one yet in your practice, I'm sure you will do. No one's exempt, as I say. I've on my team as well as individually over the years or so. And my final comment is record everything. If the cases against me came down to you didn't write it down, which was true because it was the umpteenth patient I'd seen that day and I didn't write it down. But in those days, I was able to persuade the court that my normal practice, and in fact, that was backed up by the clinic nurse who was in the room at the same time. So the court accepted that advice had been given. So, but it is much easier if it's written down. So, if anyone's got any questions or anyone would like to discuss any of these aspects further, I'm very happy to have a chat. I've tried to keep it general today, stay out of the legal aspects. I tried to give an overview. So I'd be very happy to chat to anyone who's got any interest in this area. And if they are interested in starting this area, we need more experts out there. My generation is about to pass on. New generation are finding it more difficult to do this work as their contracts don't allow them the same degree of latitude. And in some trusts, some people are actually in their contracts not allowed to do medical legal work these days, which is being tested itself in the court about whether that's a valid restriction. So with that, I'll leave you and say thank you very much for your attention.